Hello, and welcome to Bite Size MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on Epstein Barr Virus under the section of infectious diseases. The epidemiology of Epstein Barr Virus, or EBV for short, is that it can really affect any population and it has a global distribution. The variation in prevalence of EBV-related disease, it's really associated with particularly with malignancies. The classic cases that you need to know about for the MRCP is Burkitt's lymphoma, which are frequently seen in Africa, nasopharyngeal carcinoma, which are frequently seen in the Far East, and non-Hodgkin B-cell lymphoma, which are seen in immunocompromised individuals globally. So this is a picture of an EBV virion. And again, it's one of those things that has really quite classic presentations. The clinical manifestation of EBV is that in immunocompetent individuals, especially if the infection has happened in childhood, they are really quite asymptomatic. In adults and adolescents, this can frequently present as a glandular-like fever. And in other cases, this could potentially sometimes lead to complications, which we will be talking about in terms of primary and secondary sections. The primary manifestation of this frequently includes meningoencephalitis, Guillain-Barré syndrome or GBS, hepatitis, hemolytic anemia, as well as splenic rupture in severe cases, especially if there is subsequent trauma. The secondary manifestations will include primary cerebral lymphoma, especially in the cases of HIV positive and untreated patients, oral hairy leukoplakia, same in the cases of HIV positive untreated patients, Burkitt's lymphoma, nasopharyngeal carcinoma, we've already talked about, most common in the Far East, as well as non-Hodgkin lymphoma. The diagnosis is made serologically. Classically, in the exam, and most of you are probably familiar from medical school, that Paul Bonnell test provides rapid testing that basically measures the specific EBV IgM. And if you're concerned about an AIDS-related lymphoma, it's really important that you would be checking for CSF PCR for EBV, which would also yield positive results. The management of this is quite varied and sometimes even controversial depending on the location and availability to the treatment options that you have. Unfortunately, management is poorly sensitive to currently available treatments, and there isn't any specific treatment required for an uncomplicated immunocompetent case. Corticosteroids may be prescribed in severe cases, such as if you've got a patient with significant tonsillar swelling, impending airway obstruction, or severe thrombocytopenia or hemolytic anemia. And in severe or chronic cases, antiviral medications may be considered, but their effectiveness is still unclear. So this is an area in terms of its management that I would have thought is quite unlikely to be tested in MRCP exam, because there is really no set standardized treatment that is available easily for the condition. Let's do a question. A 25-year-old medical student presents with a 3-week history of fatigue, sore throat, and low-grade fever. Physical examination reveals enlarged tonsils with wide exudates, cervical lymphadenopathy, and splenomegaly. Laboratory tests show atypical lymphocytosis. Which of the following is a serious potential complication of this condition? The options are acute pancreatitis, B. pneumonia, C. Burkitt's lymphoma, D. hepatitis C infection, E. Kawasaki disease. So the Symptoms and signs that this medical student presents with is really quite classical of the EBV. This is because of quite non-specific symptoms with low-grade fever, sore throat, fatigue, and a physical examination that results in findings of tonsils with wide exudates and lymphadenopathy and splenomegaly. So remember, this is, as we said initially, in adolescents or young adults, which is the case in here, this very frequently presents as glandular-like fever, and these symptoms obviously are really quite classic of glandular fever. So if you have hopefully clicked the fact that this is EBV, you would be really quite on the right track with the diagnosis, because the potential serious complication in here is going to be option C, which is Burkitt lymphoma. Although this is not common in the UK, it's important to keep an open eye and an open mind, because you don't really know from the vignette which country the setting is. But as you know, Burkitt lymphoma are commonly a case in Africa. Thanks for listening to this episode of Bite Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.